did, but one gentleman had a severely atypical mole, which is definitely precancerous. It's not a matter of if, it's a matter of when. Almost 100% of severely atypical moles will turn into a melanoma within 5 or 10 years. So he came and we looked at it, we took it off, so coming to this lecture may have saved his life. We'll see if any of you fall in that category. So let us go to our slideshow. This is informal. I know some people are way in back, so feel free to shout out anything that you may think. When I say informal, you can yell out a question, tell me to go back or forward. We are very busy in the dermatology part of our practice. We have myself, my wife Mary, and our PA Derm Terry is back there. They'll be screening. But we get really, really busy, so we could use some help. So if any of you learned tonight how from the slides, you want to kind of tell us your pay scale, you can come and give us a hand on a busy day. You'll see these slides here. It works out pretty well. I was asked who Sammy was. Sammy is our mascot. Sammy is a snake. That's supposed to be a snake. And because our logo of Caduceus is the snake wrapped around a stick. That's the medical logo you've come to learn and everywhere. So that is our logo and our name, so we took the snake off the stick and made him our mascot. So Sammy's saying, what's that spot? So let's just do a little quiz with the first slide. That's somebody's face, that's their lip, and the spot we're talking about, the spot we're talking about is over here. You want to guess what that is? Anybody ever had one of those? What, a nipple? A third nipple? No. Oh, no. Well, some of you might say it looks like a basal cell cancer if you were here a year ago, because we put a bunch of basal cell cancers up there. You would be wrong. Doctors call that an actinic keratosis. We abbreviate it AK. Regular people call it a sunspot. So it's a sunspot. Very, very common, especially in the elderly. They're usually red or white and a little bit raised. Not very scary looking as a rule. So let's look at something else. How about that? What does that look like? Yeah, last year we had some keratoses up there, which is a scaly part of the skin. This is a keratosis, but it's also an actinic keratosis. It's just much bigger than the other ones. And this is right in the hairline, so I'm assuming it's like right up in this area here. Faces are a very common place, face and hands especially, to have AKs, so you can get them anywhere. The best thing about AKs is they're benign. What does that look like? That could look like a basal cell, but it's not. That is also an AK. You're going to get a theme kind of grouped up here. So that's an actinic keratosis. I have no idea where that is. I'm guessing it's a belly. Red, white scales on it, irritated looking. AKs typically do not itch or burn, or you don't even know you have them really. They're very, very benign and non-worrisome.
Are those ink marks above and below?
Yes, those were ink marks there because some doctor was going to take it off apparently, and that he marked where he was going to take it off. Here's a whole bunch of AKs on the arm, and this is a little more impressive looking because they're quite red. This is pretty normal looking AKs. This is not worrisome to a doctor. This is not something you would think is skin cancer. Now, AKs are interesting. This is an AK on the hand. This is a fairly large AK. By the time they get to this size, most patients want them off, and we will take them off. But even that, if we biopsied it, would come back benign, because that's another AK. You could see, though, where either an inexperienced doctor or worried patient might think that's a skin cancer, because you can make a case that that is either a squamous cell or a basal cell cancer. It has that look to it, but it's not. So for actinic keratosis, they're usually small, they're red and scaly. They're much easier to feel than to see. A lot of times the patient says, there's two on my back, and I look and I don't see anything. I go, you sure? And they go, yeah, they're there. And I go, I don't see anything. They're there, right there. So you put your hand on them and then you feel them very easily. Oh yeah, there they are. So that's common. They're definitely age-related. They're almost unheard of in the younger age groups, and they are extremely common in the older age groups. I would think it's fair to say it might be the most common benign skin lesion of the senior citizen population. It's much more common if you're fair compared to a dark tan skin, Puerto Rican skin, black, Asian. It's the Caucasians usually that get these, but any race can get them. It's just more common in the fair skin. Because they're also known as sunspots, definitely sun exposure is a major risk factor. It doesn't mean if you're had a desk job your whole life and you avoided the sun you couldn't get them, but I doubt you'd get them until your 60s if you did have a desk job because it takes some time to do it. And they definitely run in families. DNA plays a big part. If your mom or dad had some, good bet you'll have some too. LN stands for liquid nitrogen. So the easiest way to get rid of them is to freeze them. And for those that have seen me as a doctor, or maybe the dermatologist you went to, sometimes you use a little gun. I use a styrofoam cup. You put the liquid nitrogen in there, and you have a Q-tip, and you hold the Q-tip against it, freezing. That works really well. It stings a little bit, but there's no cutting, no knives, no bleeding. Just kind of falls off. It's pretty quick. There's a cream called Effudex, a cream called Imiquimod, and those will get rid of them without any surgery too. They do sting and they're a little bit expensive, but they do work. I take off a lot surgically, more or less because the patient doesn't want to have freezing, they want it off that day. And for that, you can either shave it off or actually cut it out and put stitches in. So that's actinic keratosis. Very, very, very common. Questions, thoughts on actinic keratosis? I bet you if I went around the tables, I'd find 5 or 6 dozen out there. Yes?
Is it common for them to come back after it's been cut out?
Very common, yeah. High recurrence rate.
Most common in what part of the body, or?
Face and arms, face and hand, yeah. I'm sorry? To prevent it, sunblock does help prevent it, yes, thank you. And covering with long sleeves and things like that. Hats, if you go out to ball games, stuff like that. This is the same lesion on this gentleman's back as well. That's a close-up there. Any guesses what that might be? Barnacle. Yeah?
Can we find another name for it, by the way?
Yes, we will. That's a good name for it because it's definitely related to aging. And actually, I was wrong. This is the most common lesion in seniors, not actinic keratosis. Barnacle's a good word because you get old enough, things just grow on you, whether you want them to or not. just like the pier. But I think a inexperienced doctor or a worry ward patient might think that might be a melanoma. It's black, it's ugly looking. A lot of patients come in scared to death with a bunch of these on, and I have to reassure them. Especially that. Do you have any idea what that might be? Sammy. Any idea what that might be? I think melanoma would be a good guess, except it's not. It's another seborrheic keratosis. You can see more on the right there. It looks irritated, it has a red base, it's all grungy looking, but that one I might biopsy because I think there's a remote possibility it could be melanoma, but the experienced eye would know that's a seborrheic keratosis too. We call actinic keratosis AKs, we call seborrheic keratosis SKs. Very good. So you're going to help Terry out in your office. You're going to do really well with that. Can I just do this here? Would that be better?
Yeah.
Can I just, well, it's not obeying my command. There we go.
Got
Okay.
it?
And I want to ask you, I'll just tell you, all those are seborrheic keratosis. Sometimes they're tan like this. You can barely see it. That's clearly a barnacle. You can see that gentleman's back there, and you can see how many he has. He has 4 big ones and a ton of smaller ones. And I can't tell you how many times I just had one last week where a gentleman said, take them all off. I said, you sure? Because I know they're benign. Because I hate them, they're ugly, take them off. So we were there a good half hour, 40 minutes, taking each one off, and we did. And back's 2 scars, so you probably traded those for a little scar, but that's okay. And the path report came back, seborrheic keratosis on every one of them. So we're happy to take them off, but there's really no reason to. They're always benign. That's what I was said. Most common lesion in seniors. There really are no risk factors. Actinic keratosis, fair, sun, and aging. With SebKs, there's really no risk factors. It just happens. They're almost always black. They're brown and scaly. If they're small enough, you can freeze them off with that liquid nitrogen. We call that cryo. That's the same thing as freezing. If they're big enough, like that gentleman's back I told you about, those have to be shaved off. Probably not necessary to do a full excision. The difference with a shave is you shave it and then cauterize, where an excision is you make a wide cut and sew up with stitches. You probably would never need to do that with a SebK. They're just too benign looking.
Is there any way to soften them?
Moisturizer cream does help soften them, no question. Yeah, if they're big enough and ugly enough, you have enough of them, it's probably worth taking off, but most dermatologists prefer not to, just because they know there's nothing to worry about. Any other questions on SebKs?
What causes it?
No known cause. Bad luck. Aging definitely played a major role. Any guess what that might be? You guys are good. We're going to definitely hire you after. That is a ugly wart on a finger. That's a little more advanced than most of the warts I see. Yeah, I mean, I see some like that. Usually the patient will want it off before it looks like that. How about that? Plantar wart. Very good. You guys are good. Definitely a wart, and when it's on the palm or the sole, we call it a plantar wart. Is Tina around?
Yep.
Any chance to get this louder, even or is it max?
Yeah, Max.
Okay, I'll just talk louder.
Yes.
The big difference is once they're on the palm or the sole, they almost have to be taken off surgically. They rarely go away with freezing or the acids or aspirin or Tegamet or whatever else you've read about for warts. There's a million ways to get rid of warts, and once it's a plantar wart, you almost always have to cut them out. I use a cautery. Our podiatrist here, Dr. Constantine, prefers a laser. It's his personal preference. They both work equally well. There's not one versus the other. You got to get the root of these, and it's kind of like the weed in your driveway. You pull it, and you're pretty sure you got it, and you're happy, but then a month later, the weed's coming back up. You didn't get the root. You got to go down and get the root. So I'd say with a inexperienced surgeon, up to a 50% recurrence rate. If you get a surgeon that's pretty aggressive and is willing to go pretty deep, maybe a 15% recurrence rate. Because God didn't color code the wart, you don't really know when you're in there if you got it all. There's always some recurrence rate. You're never 100% sure you got it all, so you just go as deep as you feel comfortable.
What makes the plantar wart grow in instead of out, like a wart on your hand?
Well, even the palm they go in too.
Right, but like on the top of your hand, it seems to go out.
I can't answer that. I mean, I think it's probably from pressure, I'd assume, but I don't know. How about that? What do you think that is? I see this quite a bit. I mean, this is not rare. This is very common, especially in kids for some reason. I see this a lot in teenagers. That's a finger. That is a wart. A very, very huge, ugly wart. You got to teach a little bit. If you're going to help us after, I got to teach a little Latin. So this is called a subungual wart, because in Latin the nail bed's in the unguum, so sub means under. What's scary about this is you can't see it, but this goes a good 1/4 inch under the nail in the pulp. So if you just took off this, it doesn't do any good because there's wart under the nail. So you really have to cut the nail back and cauterize the bejeebers out of this thing. I have this one patient in my Laguna Beach office, she's 77. She came in with one on her finger. She had been to 4 different doctors, and this is about 3-4 years ago. And they took it off, it came right back. They took it off, it came right back. I said, did anybody take off the nail? She goes, no, and you're not going to either. And I said, well, if I don't take the nail off, it's going to keep coming back. So I talked her into it. So we didn't take the whole nail off. We took about 3/4 of the nail back. And when I was done cauterizing it, it looked like a mouse had bitten her finger off. I mean, it was totally emaciated, black and scarred. And she said, what did you do to my thumb? It was terrible. It looked better with the wart. I said, well, I had to get the roots. But it really looked like it had gotten totally mashed up. She became my patient. I see her all the time. I just saw her 2 weeks ago. If you saw the thumb now, it looks 100% normal. You wouldn't believe it. I mean, it totally healed correctly. You just had to get rid of all that. So the moral of the story is, if you're the doctor, don't be afraid to go pretty deep and to cut the nail back and go way, way back on those. So here's some examples here. This is genital warts. They usually come grouped. They can appear solo, but frequently they're grouped together like this. Almost looks like a fern bush or something. That's the HPV. HPV is the cause of almost all warts, human papillomavirus, and that's what it looks like. Just like a little poinsettia plant or something. And here's what we see a lot of. We see a lot of, that's a finger also. You can see how many warts are there, because warts are very contagious. So they spread among your fingers very, very easily. And you can see that gentleman all the way to the right there, how many warts he has on his hand. If we aggressively cauterized those, the cure rate would be 100%, except it could come back. But we probably would do that in 3 or 4 visits. I'm not sure he'd want to have the whole hand done at once. So warts are very, very common. And let's see what the next slide shows.
How long does it take for something like that to happen all over your hand like that?
Oh, that was probably 4 to 6 months of ignoring it. Maybe more, maybe a year. This is the last wart I have. And that's what happens if you really ignore a solo wart. Almost looks like a tooth or something coming off of I assume that's his arm. There's a nickname, some people call these cutaneous horns, but you treat it like a wart, you just got to go deep enough to get the root.
What causes warts?
Human papillomavirus, HPV. It's a virus you get by touching. Because it's so common on the hands, you spread it without knowing it. Because you might have a tiny one on your hand, not knowing. You shake hands, you pass things along, and you spread it that way. So warts are benign. They're never cancerous. They're due to HPV. They are contagious. You can spread among other people. If you leave them alone and don't do anything, 2/3 will go away by themselves. Unfortunately, fortunately, most of my patients don't believe that, so they insist on getting them off. And I know what you're thinking, well, what about that guy who had them all over his hand and those pictures you showed with all the warts? Well, that was the 1/3 that didn't regress. but 2/3 will regress. You can freeze them. Freezing is probably the easiest and most quickest way to get rid of them. But you can excise them. That works out pretty, they both work. Now, a comment, because I said they're benign, in one instance they aren't benign, and that's when they become an STD. So if they appeared on male genitalia, they would not get penile cancer. That's already been proven and looked into. However, their female partner could definitely have abnormal pap smear because of the HPV and get cervical cancer. And now we know, we didn't think this 30 years ago, but now we know that just about 100% of all cervical cancer is due to HPV from the male. If you're saying, well, so how about if it's a male having sex with men, a gay relationship? Yes, that In men, roughly 90 to 95% of anal cancers are HPV related. That's new data that we didn't think that years ago. So, so we do have to keep in mind that they could be precancerous. Yes?
Teenagers are getting HPV vaccine. So
Yes.
how does that relate to warts if they've been vaccinated?
Very good. The HPV vaccine is specific against high-risk strains. The two most common high-risk strains are 16 and 18. I don't want to bore you with a lot of biochemistry, but there's probably 100 or 200 strains, and they number them. I think 32, 36, 38 are high-risk strains, but the two most virulent are 16 and 18. The HPV vaccine are specific against 16 and 18. I think the most recent one's a quadrivalent, so there's two other ones on top of that. It's given to women and men, or girls and boys, aged 12 to 26. The reason they stop at 26 isn't because they don't care about 28-year-olds getting cancer. The vaccine just doesn't seem to work much after age 26. It doesn't kick in as well. It's FDA approved for that, so it's payable by insurance companies. Recent controversy on that, some doctors won't give it. They feel that there's some side effects. Most doctors do give it. A lot of parents don't want to give it because they feel that it gives permission for promiscuity or something if they give a 12-year-old a HPV shot. The reason they start at 12, besides the fact it does work then, you want to catch them before the age of sexual activity. So if you waited until they were 21, you're going to miss quite a few. But if you started at 12, you'll catch most people before the age of sexual activity. So that's the HPV vaccine. But if I'm trying to guess what you were asking, it will not protect against the warts I put up on the board there. Because those are probably not 16 and 18. Those are probably other strains.
And while I know this isn't an STD conversation, you know, or meeting
It's a work
tonight,
conversation.
it was my understanding that those high-risk strains that the women get, the men don't, or boys don't necessarily have to have a strain that has visible warts.
Oh, exactly.
Correct. So
I'd
it's
say-
not like, well, if there's no wart, I'm safe.
No, probably 90% are not visible to the naked eye in the tip of the penis. They don't even know they have it. What's not fair is that there is no precancer from HPV in men. So they could have HPV in the tip of their penis and live their normal life and never have a problem. But they can't spread it to their partner and they could get cancer. So it's, unfortunately, it's kind of not fair like that. Okay, how about this? This didn't come out quite as well as I would have liked. Anybody have a guess on that? I'll give you a hint. It is a wart. But it's a special kind of wart. If you look at the one on the left, in the middle there's a teeny little dimple. Almost like you were using Pillsbury Doughboy and you put your finger in the middle of it and it created a little dimple. Right there. Those have it too, they're kind of painted white. This is more what we usually see. That's a kid. Look how many he has in his armpit. He probably started with one just a month before. These probably all appeared within a few weeks. We call this molluscum contagiosum. One guess if they're contagious or not. Yeah, because they call it molluscum contagiosum. Molluscum is because under the microscope they look like clams almost, and then contagiosum for obvious reasons. They are 1,000, 2,000, 10,000 times more contagious than warts, but they are a form of a wart than HPV. These are not due to HPV. I've had entire preschool classes come in with these because they're so catchy. Adults get these, but for adults it usually is an STD, meaning these occur pubically. With kids it's almost anywhere because they spread in the playground so commonly. A decent percentage will go away on their own, but you really should do surgery because by the time you're waiting for them to go away on their own, they're quadrupling. One story is I treat my own godson. He's now 30 and married and has a kid. But when he was about 5, his dad, my best friend, brought him in with one on his back. And I went to take it off, and my godson was screaming and yelling and kicking and, no, you can't touch me out, it hurts, don't do it, because you have to numb it. So I said, okay, let's bring him back in a few weeks and look at it then. So probably bribe him with ice cream, bribe him with toys, whatever it takes, but bring him back. So he came back maybe 3 weeks later. He must have had 20 of them.
Oh.
And now poor kid really had to be held down because I had to give 20 Novocaine shots. And it looked just like that, but it was on his back. So here's a real case of a real kid, and that's kind of what my godson looked like right there. I think that's a back. Could be a belly, but I think it's a back. And each one of those is a molluscum contagiosum with the little dimple. Now, for those of you who are going to help me take them off next week, I'll tell you that in the top of it is a little dimple. Under the dimple is a little white pearl. It's about the size of a period on a typewriter, and it's white. You got to get that pearl out. You got to. So normally it's what you call unroof them. That's why we numb it. So we numb it with Novocaine, so it does sting, and then we use a special blade that's really, really, really fine. We just open the top, unroof it, and then using a special instrument, we pop out that white pearl. Now, a lot of doctors, especially pediatricians, because pediatricians usually don't like getting their hands dirty, so they don't do surgery a lot. They'll freeze it with liquid nitrogen. It might work, because liquid nitrogen might destroy the whole thing. But really, to get the 100% cure rate, you've got to get that little white pearl out of every one of them. So if this patient here came in to see me, I'd book a good 45-minute case, and I would numb every one of them, and I would pop that pearl out of every one of these, and then they'd be cured. The trouble is, auto-inoculation is so common. In plain English, self-spreading, spreading to yourself. So even if I took all these off in one setting, there's a decent chance that a month from there you get 2 more, because they were inoculated, but they weren't visible yet. So respect molluscum contagiosum, if you see them, if you have it. And realize that not every ward is a HPV ward, but could be this strain. Yes?
So is that the same thing as what used to be called the rhizome?
Rhizome. Anybody older than me out here who's going to answer that? Terry, you've heard of the rhizome?
I couldn't hear the question.
A patient asked, is this what used to be called the rhizome? Molluscum contagiosum. Got me on that one. I've never heard of the rhizome, but I think my wife has an iPad. You can Google rhizome and tell me what that is. So, molluscum, that should say contagiosum, because it's Latin. It's also a virus. That little central dimple I told you about, extremely contagious, and especially to yourself. Cryo only works about half the time. You got to get the center of that pearl out. Questions? Yes.
With all these recurring barnacles or warts, is there such a thing as detoxing the body or the system?
I'm afraid not. Not for what I've shown you so far anyway. Well, I'm getting to things that maybe we could do that with, but not these. These are, somebody with a virus touched you, and you could have the cleanest immune system in the world, you're going to get the virus. It's not going to stop that, I'm afraid. How about that? Anyone want to guess what that is? Well, you guys are good. Of course, it kind of looks like a worm, doesn't it? It kind of looks like a big worm crawled around there. And that's another lesion there. Doctors don't call it ringworm. We call it tinea corporis. Tinea is the word for fungus, because as you probably know, it isn't a worm at all, it's a fungus. But many, many, many years ago, before they had microscopes, they thought it was a worm. So that's why they call it ringworm. And corporus means body, so basically it means you have fungus on your body. Remember when you were in grade school or high school and you would take Q-tips and you touch something and you go to the little brown plate and you spread it, put it in the oven, and then the next couple of days there'd be these round colonies on those of something. So that's what these are. This is your body being a brown agar plate, and this is the colony of fungus growing on you because it likes you. How about this? Guess what that is? It's a much less obvious case of ringworm. So that's also ringworm. The first one was kind of like, we say it's a freshman medical school student diagnosis. Almost anybody could make that. But this is a little harder. You could almost argue those are AKs, like we showed at the beginning of the talk. Little red spots. You could almost say they look like basal cell cancers, too, in a way. But they're ringworm, tiny little colonies. Doesn't always have to be a big, huge colony. And sometimes it's very dramatic looking, such as that. That's somebody's upper chest, and very, very pronounced. We don't see this very often. If I saw this in my office, I probably wouldn't think ringworm right away because it's so pronounced, but that's what it is. It's also known as tinea corporis. It's a fungus, not a worm, like we said. I should say plaque, not plague. It's around plaque. It is, a true statement is, it's one of the only real rashes that is possibly transmitted by an animal, especially dogs and cats. So I know when I was a very young medical student, I thought, you can't get ringworm from a dog. I mean, that doesn't sound right, but yes, you can. Because it is catchy. If you're prone to get a fungus, you can get it from another human being or you can get it from an animal.
What part of the animal is
Skin, anywhere on the skin.
like their tongue with their
Sure. Yeah, if they have fungus there, sure. If you use antifungal medication, there's a 90 to 100% cure rate, but it may take months. I think I've had some ringworm take 6 or even 9 months of daily cream to finally go away. So it's like watching water boil. You have to really convince the patient to hang in there because it takes a while sometimes. Ringworm, of course, is very, very common and very rarely anything to worry about. Most doctors can diagnose it immediately, but I end up biopsying quite a few, and I'll show you why. You want to guess what that is? I would think, what I would think in my office, and what I hope you're thinking is that's ringworm, but it's not. So that's why you may have to biopsy it, because there's something that looks exactly like ringworm that isn't ringworm. We call it granuloma annulare. In Latin, annulare means round, and granuloma means it's scar tissue. They have no idea what causes it. This is a more pronounced case of granuloma annulare. If you treat it like ringworm, it doesn't go away. So it would help to biopsy these, especially if you're not sure what it is. When I say biopsy, we take an itsy bitsy teeny weeny bit of tissue, and then we send it to the lab, and it comes back either fungal or granuloma annulare. That looks like ringworm to me too, but it's not. It's granuloma annulare. You might say, well, gee, I've heard of ringworm, I haven't heard of this. I guess because I think a lot of times it's misdiagnosed. It's not that uncommon. I see a good 3 or 4 cases a year. Of course, I see 100 cases of ringworm, so. It's a benign inflammation of the skin. It's really indistinguishable from ringworm to the first time you see it. You have to kind of have some experience to suspect that's what it is. We don't know the cause. They keep saying it's one of those autoimmune things where you make antibodies against yourself, but there's very little evidence that's really what causes it. It says young adults. I can only think of 1 or 2 cases in my career where it was a man. It's almost always women. So that's one hint I have sometimes if it's granuloma annulare or not, is if it's a woman, I think more likely it could be. There's no treatment whatsoever. If you used antifungal meds, it wouldn't work. You could cryo it, freeze it. You could use topical steroids. You're really treating the patient more than you're treating the lesion because it's not going to probably go away. It'll go away by itself, 6, 9, 12 months, and it'll fade away on its own. So any questions on ringworm or granuloma annulare? Yes?
How long do you, like you said, the preschooler, how long can they be out from school because it's highly contagious?
Once they've had 24 hours of a cream, they can go back to school. I know sometimes they don't want them to go back to school, but I don't support, and I think the American Academy of Pediatrics does not support notes for school for ringworm. So you can, as long as they're getting the cream on it, they can go back right away. Okay, want to guess what that might be? No? It's something I bet a lot of people in this room have had. I've had it. That's a cold sore, AKA herpes simplex virus. So that's herpes of the mouth. This is a special kind of herpes. That's a herpes lesion, but you see this white spot by the nail? There's a specific name for that doctors use, and it's a really bad herpes. Now, it's the same strain that gets the lip, so you can get it by touching your lip, picking at it, that kind of thing. And we call this herpetic whitlow. I don't know why they call it herpetic whitlow. Well, the herpes part's obvious. I don't know what whitlow means. I think it's one of those names that have been around since the 19th century, and they just kept calling it that. But it's basically a herpes simplex virus of the finger. But because it gets into the nail, it really, really hurts a lot. And because it's under the nail, the usual herpes medicines don't work very well. It's really something you wouldn't wish on your enemies because it really, really hurts. This is more what you're probably used to, the arrow helps there, but that's a classic herpes simplex virus of the lip. I don't think many people would miss that. It starts off as you can usually feel it at the very early stages before it even looks like anything. It tingles, it hurts a little bit, feels a little sore, and actually the bigger it gets, the less you notice it, the less it hurts then. Eventually that will scab up, and once it forms a scab, it's no longer contagious. Until it scabs, it's very contagious. And then the scab falls off and doesn't scar. This is an example of herpes simplex of the mouth, but a lot of little tiny blisters. So it could be one big blister like that, or it could be dozens of itsy bitsy tiny blisters. They're both herpes simplex. Now, I didn't put a picture up there, I wasn't sure what kind of audience we're having, but imagine that exact thing on a penis or a vaginal area, and you have herpes 2. This is herpes 1. Herpes 1 is usually above the chin, herpes 2 is below the belt, and the herpetic whitlow is usually 1 because you get it from touching it. So it's a virus. It's very, very contagious, also to yourself and to others. It starts with pain and tingling before you see the lesion. There are herpes antibiotics. They definitely reduce the number of days you have it, but they may not cure it. So if you took penicillin for a strep throat, it's killing the strep, you're cured. If you take the herpes antibiotic, it lowers the number of days, but the herpes stays under your skin and reappears whenever it wants to. It usually reappears with things you know a cold sore does. Fevers, wind, high temperatures, low temperatures, trauma. I see a lot of people come in because they get hit in the mouth with something and then the lip has a cold sore on it. And it's very recurrent. The first one's the worst. By the time you've had your 5th or 6th, it's not that bad. But if I see a 10 or 12-year-old with one, I'm 99% sure he's going to get another one in a few years. So questions on herpes simplex. This is something maybe, I don't know about a cleanse, but I think a stronger immune system would help this one quite a bit. Is that herpes? I heard somebody say the last slide was impetigo. It wasn't, but this is impetigo. So, but again, to the untrained eye, it kind of looks like herpes, right? I mean, it's on the lip. That's somebody's lip, and there looks like it could be a little bit of blister, but it's not. Impetigo can hit adults too, but we think of it mostly as a pediatric. So there's one, a kid, the classic impetigo, all over the nose, mouth. He probably had a runny nose, and that's kind of where it dripped down to. And then he drooled a little bit, got in his mouth. Beautiful blue eyes, huh? And this is a less severe case. This is something that maybe some doctors might miss, because it looks like maybe he just ate a bunch of McDonald's fries or something and it's still on the mouth. It doesn't necessarily look like impetigo, but it is impetigo. You can get impetigo other places than the mouth. You can get it on the arms. You can get it anywhere. I saw a case recently on the back, so you can get it pretty much anywhere.
My daughter started on her foot and traveled as she touched it, not
Mhm.
knowing what it was,
Right.
all the way up her body until it was on her face. Before we finally went,
Yeah.
that, you probably
Common,
need to go.
well, not that common, but doesn't surprise me at all. So it's the most common bacterial infection in children, so it's very, very common. Remember, this is up against common colds, it's that common. It's almost always due to staphylococcus. I think a very small percent might be strep, but it's almost always staph. And it's very, very contagious. Another thing that in nursery schools and kindergartens gets spread like wildfire. It classically has, and this is a good hint if I'm going to hire you after, it looks like a honey crusted. It has that, it looks like honey that's around the side of the honey jar that's kind of crusty. That's classic for impetigo, kind of a yellowish, goldish crust. There's really no reason to test, and I've had some very spirited discussions with my patients who insist I run some culture or blood test or something, because I don't know why. I think, maybe you can tell me, but there's a stigma like you're not keeping your kid hygienic, or you're a dirty family or something if you have impetigo, but you're really not. It has nothing to do with that at all. It's extremely contagious. If one of your kids get it, he probably got it from another kid. It had nothing to do with your house. And almost every competent doctor could diagnose it in about 10 seconds, so you really don't need any tests for it. You can culture it, that would tell you, but it's just a waste of time and money. But adults do get it, and I've seen adults not that rarely. And you treat it the same way. And adults get it from kids, or adults get it from other adults, so it can happen. The good news is it responds very quickly to antibiotics. Stuff you treat staph with, like Augmentin and Keflex and things like that, it goes away right away, within days. So at least it's very easy to treat. Okay, how about that? Anyone want to guess what that is? Let me show you another case, maybe it'll be more clear. This gentleman had it on his hand. It's on his left hand on the top. I'm assuming it started here, but then it spread in his whole hand, and it really, really hurts a lot. He might have a low-grade fever. He can barely bend his fingers. It hurts not even to touch it, meaning it really hurts to touch it, but it hurts even when he's not touching it. He may even be able to sleep with it. There's a more classic example of this. We see this a lot in the office. I don't know if that's a back or a chest. Let's say it's a chest. Little tiny pustule. There's pus right there. It's kind of mean looking though. It doesn't look like a typical abscess, does it? It kind of looks meaner. So let's see what the derm gallery in back think. Mary and Terry, you want to yell out something there? No comment. Okay, get rid of them, get you guys in. This is a more advanced case. Very popular in the media recently. It's on TV a lot. It's on series. It's nicknamed MRSA or MRSA. Most doctors still call it MRSA, but on TV they call it MRSA. It's a very, very resistant strain of staph. It's gotten to the point where it's commonplace. It's not by any means rare, and it's a bear to treat. And it really hurts very, very badly. This is a case where the patient got it right in front of the ear, and there's one in the middle of the back. And I'd say, well, these are extreme examples I found on Google. No, these are things I've seen a lot. I've seen a handful of these since January. I've seen about a dozen of these this bad since a year ago. So it's by no means rare. Very, very common. I will tell you. It stands for methicillin-resistant Staph aureus. The only word of all that you have to remember is the word resistant. Antibiotics just don't work against it. There's an antibiotic called Septra that's maybe 80% Remember, doctors don't like 80%. Doctors like things that are 99% effective. To us, 80% is terrible. And then there's clindamycin, maybe that's 75%. There's Keflex, which is like 40%. So you find yourself sometimes just giving the antibiotics hoping that it gets better. It was used to be only in old people, nursing homes, and hospitals. And frequently the patients died of it. When, I'd say the 1990s, if they said your grandma had MRSA, and she's in the nursing home, that was pretty much the ballgame. They would get septic and they would die. But starting around 02, 03, 04, we noticed young people getting it, healthy people, especially athletes. I can think of a couple baseball players last year that went on the disabled list specifically because of this. I think it's because of the locker rooms and the sweat and you're touching each other, and because it is contagious. So now it's not uncommon to see it in normal everyday people. They usually come to the doctor, or they wouldn't for a normal pimple, because it hurts so bad. And if you don't treat it, it gets pretty big. Very contagious, very painful. It also drains itself. Most pimples don't drain themselves, if you notice. You might squeeze them to open them up, but on their own they don't drain. But MRSA drains itself. It's kind of like the body's trying to heal it. But the pus doesn't come out. You don't see that yellow or green pus you get with a normal pimple. It's usually very clear or just blood tinged. And that's the clue you have MRSA, is that when a patient comes in with a pimple and you go to open it up and clear stuff comes out, it's probably not a regular pimple. If it gets into the bloodstream, though, it can be very, very serious. So the idea is you want to get it early. So to answer the question I was just asked, if you look it up in the books, it'll give you all these antibiotics you could use, with the ones I just mentioned to you. And they'll say, don't give it for 2 weeks, give it for 4 weeks. Don't give it for 4 weeks, give it for 6 weeks. But really, anybody who's treated this, and the head of infectious disease at UCI gave us a talk at the hospital last year, and he was right on the money. You got to open it up. You got to numb it. You got to get a special scalpel. You got to slice it open. You got to drain it all out and pack it. You just got to open it up. Once you open these things up, they feel so much better. According to the statistics, you really don't even have to use an antibiotic if you open it up. I can guarantee you almost every doctor I know will give the antibiotic because that's the current marketplace, but you probably don't need to. I hope nobody out there gets this. Maybe some of you have had it, because I see it quite commonly. If you think you may have it, get in right away, because the sooner we can open it up, it's not that big a deal. But if you wait, it turns that thing in the guy's ear there, it can really, really hurt. And if it gets into your bloodstream, it could be very, very serious. Yes?
Yes, and the wound is open. Do you leave it open?
No, well, I don't. I put on, Bactroban is a antibiotic cream, and that has very good properties against MRSA. So what I do is put the antibiotic cream on, a Telfa, and a wrap, and you change it twice a day, and maybe a week later you can leave it open. That's how I do it. Every doctor, it's kind of the art versus the science. There really isn't that much data on that, but that's how I do it. The best treatment is training. What do you think that might be? I'll show you another one. These are kind of fun to take off. As you can see by the size, it's pretty small there. All of these are filled with blood. So these are blood-filled tumors. We call them hemangiomas. But they're very common, and they're very, very benign. I see these almost every day. I see them as part of a physical where the patient doesn't even know they have them. So I mean, they're extremely common. Typically, you reassure the patient because there's really nothing to do with them. They're very benign. This doctor apparently wanted to take that one off. Oh, wait a minute, let me go back. Okay, I'm off by one set of slides. Let's do this again. This is not a hemangioma. There's that, there's that, there's that. This is a very common lesion. We take off a lot. When I got here, I realized there was an hemangioma. This doctor, of course, is going to take it off because he drew the marks for doing surgery. We call these dermatofibromas. Dermato means skin, obviously, and a fibroma is some scar tissue. They don't know what causes them. They're extremely common. They're always benign. They never turn cancerous. One popular theory is that maybe a pore got plugged and the body built up some scar tissue where the pore got plugged and then stopped and it left these kind of nodules. These are small nodules. Typically, these come off because the patient wants them off. Doctors don't really need to take these off. They're very, very common and very, very benign. Dermatofibroma. They really don't know what causes them. They don't really itch or hurt. You don't even know you have it until somebody points it out to you. The only time myself, and I think probably Terry and Mary would agree with me, you take them off is if the patient asks you to, because you want to be nice to the patient, but there's really no reason to take it off. Now, this, I believe, is a hemangioma. That's a child's scalp. That whole thing is full of blood vessels. That's a blood vessel tumor. Excuse the printing on top, but that's more obvious. See how red it is? Obviously, it's a hemangioma. Have you seen this in friends or family members or your parents, those little tiny red dots everywhere? Those are called cherry angiomas. They're called cherries for obvious reason. And it is definitely a benign condition.
Oh, okay, like this one, in our family, we just call that a strawberry, and eventually they seem to go away. Is that?
No, I don't agree. I agree it's called strawberry. I have another one there. Let's see. There's a strawberry. That looks just like a strawberry. And that's on a child's buttock. Strawberry angiomas, like that one, are almost always there at birth. There might be cases or anecdotes where they have gone away, but typically they don't go away. They have to be lasered off as a rule.
Is there something else that looks like that goes away?
The other one, the non-strawberries, the smaller ones. Strawberries are big, that's why they're called strawberries. So for example, those might fall off. Even the middle one might, but that probably won't ever fall off. They have to be lasered off. They're not even cut off because they're so vascular. Now you have to look carefully there, but this we call a spider angioma because here's the blood vessel tumor, and here's all the little blood vessels coming off. So we call that a spider angioma. They're common in kids and adults. Basically, the blood vessels came to the skin surface and then broke, and then you got the sunburst effect. Totally benign. You'd have to cauterize or laser that off as well. Now this is a very special lesion, very common in pregnancy. It does have blood, but it has pus in it too. It's very common on the fingers, so here's one on the finger, and it's very common on the nail. We call this a pyogenic granuloma. Pyogenic means it started as pus. Granuloma means it's scarred down, so it's a scarred down pus pocket basically. I'm not sure why, but it's very, very common in pregnancy. Very common in young people, less common in the seniors. But when you go to cauterize this, it bleeds like crazy. So that's why I put it under here with the angiomas. Whenever you take off a hemangioma, it always bleeds and bleeds and bleeds and bleeds. So you need your nurse next to you with a stack of gauze that big because it just keeps bleeding. And that's a strawberry on the buttock. It's very genetic. There's no other cause I know of. They're bright red and they're full of blood vessels. There's really no need to treat it unless it's growing quite large, or sometimes they'll bleed on their own. Once they start bleeding, you want to take them off because you don't want to be on vacation somewhere and have bleed on you. It's best to cauterize. That's probably the only way, really, I think, to take them off easily. And you can cauterize with the cautery we have in the offices here or with a laser. Okay, how about that? Yeah, somebody said melanoma. Yeah, I could see that being a melanoma. Do you guys remember from last year your doctors, the A, B, C, D, E? Because that's how you tell. So the A stands for asymmetry. In Latin, A means not, so it means not symmetrical. And this is not symmetrical. B stands for the borders. If the borders are irregular, that's not good. Well, the borders are definitely not regular, that's not good. C stands for color. We don't like black, we do like brown. That's black, so that's not good. D stands for diameter. 7 is the cutoff. Over 7, very, very likely a melanoma. Under 7, probably not a melanoma. I don't have context there, but I'm guessing that's about 7, so it's right
7 what?
between there. I'm sorry?
7 what?
Oh, I'm sorry, millimeters. The rule of thumb is it's the size of a pencil eraser. So pencil eraser is about 6 millimeters, give or take.
Doesn't have to have all of those things. Or
No.
could it have the diameter and
Could have
nothing
just one of
else?
them. And then the E stands for evolution, which is a fancy way of saying changing. They would say change, but they already use the C on color, so they had to think of something else. So they call it evolution. So if you use the A, B, C, D, E, and I don't know what this looked like a year ago, but if you use the A, B, C, D, E, that's a melanoma. But it's not a melanoma. And that's why you have to get skin screens, and that's why you have to have biopsies, because even the most experienced doctor would think that's a melanoma. We actually, there's another one coming up here, I think, if I'm not mistaken. It's called a Spitz nevus. A Spitz nevus looks just like a melanoma, but it's benign. So that's always a very nice thing. I had a gentleman in my Laguna Beach office who loved the beach. He's in his mid-50s, and he had the ugly mole. It was bigger than that, looked uglier than that, right in the middle of his back. His wife had been nagging him for over a year to get it off, and he had ignored her. Finally, she drug him in, and I wouldn't let him go home. I said, we're taking it off right now, because it's just, and I just assumed it was a melanoma. It looked terrible. I felt bad. He's a good patient of mine. I felt terrible for him. Path came back 5 days later, Spitz nevus, benign. So that was very, very heartwarming for me. So there's no way anybody would know that's a Spitz nevus without biopsying it. No gray hair professor at Mayo Clinic Dermatology could ever use his experience to tell that. This is a benign nevus, but again, you may not think so. Nevus is a fancy way of saying mole. Look all the little black little areas there. Again, I think the average doctor and patient would assume that's cancerous. Looks cancerous to me. That is a atypical nevus. So when I take a mole off a patient that looks ugly, the way I describe it is there's 5 possibilities. The first and the fifth are pretty obvious. The first possibility is it's benign. Then you're done. Don't worry about it. The fifth possibility is melanoma. If that's the case, we got a lot to talk about. There's referrals and x-rays and a lot of stuff we have to do. But there's 3 possibilities in between: mild, moderate, and severe atypia. Remember when I started the talk, I told you a year ago somebody in the audience showed me a mole, we took it off, and it was severely atypical. Mild atypia really is normal. And I believe, in my opinion, you can treat mild atypia by watching it. You don't have to do much about it. Just assume it's normal. Basically means the pathologist is covering his rear end and just wants to say it's mild, but no big deal. Moderate could turn into cancer. Could be precancer. There's enough weird cells in the slide that you worry it could have turned into cancer. Severe atypia, the studies show, almost always turn into cancer. So the idea is you want to get it when it's mild to moderate, not when it's moderate to severe. I believe this is moderate, just because of the article I read. This isn't a picture I took. But you could see where you would have no way of knowing. I'm almost 99.9% sure that's benign. Want to guess why I'm saying that? Hair. Yeah, it's not something that they talk a lot about in med school, but they should. Hair coming out of a mole is almost always a sign of benign. Now, it could be atypical. The reason is the melanoma cancer cells kill the hair roots. So I do worry when I have a hairy patient with hair all over them, and I see a mole and there's no hair coming out of it. That bugs me a little bit. This is an extreme example, but if a patient came in and showed me that and wanted it off, I would bet $1,000 against a dime that it's benign, and I'd be right. My whole career, I don't think I've ever had a melanoma with hair out of it. So I wouldn't run to the bank on that, but that's a pretty good way of knowing. So if you're checking yourself in the home in the morning, and you're in the mirror and you're looking at yourself, you see air coming out of it, I think you're pretty safe to just watch it. This is something I see a lot. I see this more in kids. I don't know if this is my practice or if it's more in kids. It's called a halo nevus, and it's obvious why. You see the halo around it. I get this all the time. I had one in January, and a very worried mom came in and did not want to leave till I took it off. And I assured her it was benign, and it was ugly like that. That's kind of an ugly mole when you think about it. But I said, I know it's benign, and she said, well, how do you know it's benign? I said, because it has a halo around it. She said, no, that's why I brought him in, because that halo is scary. It looks like it's serious. And I took it off, and it was benign. It was a halo nevus. They're not really that rare. You can see them. Again, I think more in younger people. So if you see a mole on yourself or your loved ones and it has a halo around it, relax. It's almost always benign. Now there's an example also of what I would think is melanoma. You do the ABCD, I think it only might fail the size. It looks terrible to me. I don't know. It has a black thing in the middle and irregular borders, and it's black. And, this is a severe atypia. This is a precancer, not a melanoma. Similar to what I took off that gentleman who was here last year. You want to guess what that's called? Do you see her pretty blue eye? Can you imagine the mole actually has a blue tint to it? It does, because we call this a blue nevus. This is another case, and I see this in all ages. This is usually where the patient comes in saying, I'm dying, I guess I better get a will, what cemetery do you recommend? I go, what are you talking about? Well, look at this mole, it's blue. I go, yeah, it's blue. Well, that means I'm going to die because it must be one of those weird melanoma things. Blue nevi are always benign, always. So nothing to worry about there at all. We take them off, I think, more because nobody likes having a blue mole. I don't know. They have no problem watching a brown or black mole, but they just don't like having a blue mole on their body. I don't know. So I would take, even though it's on a pretty girl's face, I would take that off and put a couple stitches in just to reassure her. That's also a blue nevus right smack dab in the middle of somebody's forehead. That's easy to take off because you can bury the scar within the lines of the forehead, so that's pretty easy to do. And that's also a classic blue nevus. So I showed you a lot of blue nevi. Because when I say blue nevi, you're probably thinking like maybe turquoise. It's not that kind of blue, it's more dark blue. So moles are also known as nevus, nevi. There's dozens of different types. I showed you a few spits and a halo and blue. If you get a lot of sun, if you get older, and if you have it in your family, you get atypical moles. I'll talk to you about that in a second when I get to melanoma. And I already gave you the story, mild, moderate, severe, on the atypia. And if they're less than 7 millimeters, they're probably benign. That's the size of a pencil eraser. You see this lady's face. See that very often? What do you think that might be? Yeah, I would call it an H spot. I found that my practice suffered if I called them H spots. So the businessman in me tells me never call them H spots. Here's an example, a whole bunch on the hand. Yeah, same exact thing. So you may have heard this condition before. I find I can keep my practice intact if I call it by the official medical term. These are benign lentigos. Lentigo is the medical term for these age spots. This is common. Here's a gentleman's all over his back. Look how many he has. And sometimes the wife will send him in saying, he's got so many moles, one has to be a melanoma, but it has to be. Look at how many he has. But every single one of these is a lentigo. And lentigo are almost always benign. I'll give you an example of one that isn't benign in a minute, but they're almost always benign. This is an example of a lentigo that is scary looking. Look at how it has all these lines in there and how ugly it looks. As ugly as that is, that's 100% benign. Nothing to worry about. This is more common what you see. A small oval, ovoid, brown spot on the face of a senior. That's common. Can kids get Lentigo? Yeah, but not very often. It's almost always a senior moment. Should be an L there, Lentigo. They're dark, they're tan, and they're never raised. They're flat with the skin. Usually circular or oval. A lot of different kinds. And they're almost always benign. I talked everybody out of treating them. Some people really want them treated. The only way to treat them is a laser, because, and not just a regular laser, but you go to these anti-aging places that charge several $1,000s to do it. It's hard because it's fairly deep in the pigment of the skin. Now, if anybody's disappointed because you came thinking we were going to talk a lot about skin cancer, I did that last year. I wanted to show everybody this year there's a lot of things that look like cancer that aren't cancer. But to not disappoint you, I'll show you some skin cancer, because when we go to screen you guys, whoever wants to be screened in a few minutes, that's primarily, I don't think you're going to ask if you have a Lentigo or ask if you have a wart. You're probably going to ask, is this cancer? So let's give a quick primer. There's 3 kinds of skin cancers: basal cell, squamous cell, and melanoma. Basal cell and squamous cell really are curable. Now, I hear more and more about squamous cells spreading. I think in the textbooks, I can think of a rare case, but it's probably, you're as likely to die of a squamous cell skin cancer as you are getting hit by lightning. So it's pretty rare. Basal cell never kills anybody. So if you're going to have a skin cancer, a basal cell or a squamous cell are the ones to get. Melanoma is the one that can cause death at a young age. So those are the ones you don't want to miss. Basal cells, the reason why the author of this slide told you what it was and was nice enough to put little arrows to show you where it is because that's a typical kind of basal cell. They're tiny, they're pink, and you wouldn't think they're skin cancer. So I had a patient come in about 2 weeks ago in Laguna Beach. It was right up here, on right his eyebrow. He's like 80 years old, and it was a teeny red dot. Smaller or about the same size as a period on a typewriter. I mean, that's small. And I could barely see it. I was squinting saying, what do you want off? He goes, I want this off right here. And so I had to get a mirror to make sure I was looking at the same thing he was talking about. And we got a little marking pen I marked. So that little thing right there, yeah, that right there. Well, why do you want that off? Because his face was spotless otherwise. He goes, well, it's new. And I said, yeah, but you're 80. It's a sunspot. He goes, I don't like it. So I shaved it off. Came back a basal cell. So, of course, in Laguna Beach, there's a lot of basal cells because the sun causes basal cells, and Laguna Beach has a lot of sun. So you can see how easy it is to miss a basal cell. Fortunately, they are benign, but I don't think anybody in this room wants to have a skin cancer on their body and not take it off. So naturally, you want to take it off. The circle helps here too, but this is also a basal cell. This is what happens if you don't take it off when it looks like that. So you might say, well, what? It's so small. What if I ignored it, didn't go to the doctor, and waited a few years? Well, you wait a few years, it looks like that. So it starts to ulcerate, gets bigger, gets redder. I don't think most people would not want that off. I think the average patient would come in saying, please take that off. That does look a bit ugly. That is a squamous cell. You can't be dogmatic, but usually basal cells are flat and pinkish, and squamous cells are usually nodular and raised. But again, you can't always tell that. But you can see how it's raised. Look at all the blood vessels in there. Blood vessels aren't good. That's what cancer does to the skin. It's a nodule. That, I think, any doctor would think is a squamous cell. So if you see anything like that, it's got to come off right away. I take off a lot of squamous cells. We see those a lot. What's scary about those, although they're 100% curable, is they'll go from nothing to that in a week. A patient will come in with that and they'll say, this happened last weekend, I don't know what it was. A lot of times they think it's a bite. They'll say, I was outside by the pool and there were mosquitoes, so I think it's a bite. It just happened 5 days ago. But No, it's a squamous cell. That is a squamous cell that you waited a little too long for. Now, last year I had some real horror story pictures. I'm not going to show those to you, but see how it turned really white and not in thickened there. So this whole thing is just a large squamous cell. Even that is 100% curable. We would have to do a wide excision. We'd want to go like that, and like that. Put 2 layers of stitches in, and it'd be a pretty big scar. But who cares as long as it's curable, right? So that's a good thing. Okay, we stopped there. Are there any questions about lentigos, nevi, basal cells, or squamous cells? Okay, so let's finish with the melanomas. That is a melanoma. The only reason I know that is I typed melanoma into Wikipedia, and that's what popped up. To me, it looks very, very much like one of the atypical moles that we showed you a few slides ago, which is more proof that you really can't tell. But the idea is if you're high risk, and high risk is the things we've already talked about: fair skin, blue eyes, green eyes, blonde hair, auburn hair, sun exposure, a positive family history of skin cancers, or if you've had a basal cell, your chance for melanoma goes up like 10 times. If you've had one kind of skin cancer, all the chances go up a lot. So you should get an annual check, and you should look for the ABCDEs of these things, and let your doctor map it or take a picture of it and keep an eye on it. It's always better to take something off too early than too late. And you always want the doctor saying, this is probably nothing. You don't want the doctor going, ugh, this isn't good. So I would be worried taking that off for my patient. But in this case, it wasn't melanoma. I told you earlier that there were several lentigos that were cancerous. They give them a name, lentigo maligna. Malignant lentigo, it's Latin. Lentigo maligna are lentigos that turn cancerous. Now, for those of you that have them, I see a few out there, you go, oh my God, maybe mine's going to be that malignant thing. No, because these are the ones that are usually on the white of the eye. You've heard of melanomas appearing in the white of the eye. That's a lentigo malignant, usually. So I'll show you a lentigo malignant. It's a melanoma, and probably the biggest nightmare, because these lentigo malignas are not necessarily related to genetics or sun or skin. As a matter of fact, they're fairly common in the black race, where regular melanomas are not common in blacks at all. And that's one there. So that is a melanoma that started as a lentigo malignant. So it started as a brown spot under the nail that then evolved to this. That's a different patient with a different, these aren't the same fingers, but you can see a different case on your right. That's also melanoma of the nail. Places that should get looked at and taken off right away are anything on the sole, palm, eye, inside the mouth, and nails. Last year when we screened here, one patient did have a decent sized mole on one of his toenails. And so we took off the toenail, took off the mole, came back a lentigo. Not malignant, just a lentigo. So you could argue that maybe that would have turned into a cancer, I don't know. But if you have a mole in any of those places, go to your doctor immediately. The odds are they'll take it off no matter how big they are. Questions on melanoma? Okay, now that I have you all scared to death, yes.
Are they generally raised or are they?
Both. Both. They can be raised, they can be flat. That's what makes them so scary. Yes, ma'am?
Is there such a thing as a melanoma disease if you've had 3 or more?
I'm not aware of melanoma disease. If you've had 3, your chance of a 4th is extremely high. Maybe 80, 90%. Yeah, so. But that's when I say, usually after I take 1 off, we say every 6 months. If I've taken 2 off, I'll say every 4 months. I think if somebody had more than 2, I'd say every 2 to 3 months. Because it's a quick visit otherwise. And then if you see them every 2 to 3 months, whatever you're taking off is only changed in the last 6 or 8 weeks. So you're getting it very early. It's very, very rare to have a melanoma that spreads and causes death if you catch it early enough. It's really the ones that you wait on that are the scary ones. So, we've all been very patient watching all these horrific slides on the screen there. I'll repeat what Tina said, then I'll give her the mic and we can begin. By the way, you don't have to be screened if you don't want to. Just if you want us to look at any spots on you, just tell Tina. We'll put you in a room and we'll take a quick peek and let you know what that might be. But to repeat what she said earlier, this is a series. Dinner with the Docs. We try to do about 4 a year. We feed you. We give you wine.